Okay. Good afternoon, good evening, everybody, and welcome to the second Wound Healing Society webinar of 2025, which is on the topic of pressure injuries in persons with spinal cord injury towards innovation or convention. Please note, if you have any questions throughout this presentation, use the Q&A box and we will address as many questions as possible at the end of the webinar. And as a reminder, the webinar is being recorded. So I will now hand this over to our moderator, Dr. Foy White-Chu.
Hi, thanks for joining us this evening. I'm Dr. Foy White-Chu. I'm an associate professor of medicine at Oregon Health and Sciences University and the medical director of the Wound Healing Center at the Portland Healthcare in VA. And I look forward to welcoming Dr. Letitia Graves. She's an assistant professor at the University of Texas Medical Branch at Galveston School of Nursing, and she holds a joint appointment at the Lewis Stokes Cleveland VA Medical Center as a research health scientist. She earned her PhD in nursing from the University of Pittsburgh with a minor in healthcare genetics. And what I think is really fascinating about what Dr. Graves does, because I am also a geriatrician, is her research includes the social epigenomics, things like diet, sleep, exercise of disease, and biological aging. She's specifically exploring DNA methylation and epigenetic clocks to phenotype chronic multimorbidity and accelerated aging in people with spinal cord injury. The long-term outcome of this work will help support the integration of diverse measures of data into a comprehensive clinical picture, supporting the expansion of precision medicine and clinical risk prediction for individuals aging with disabilities. Dr. Graves, take it away.
Thank you so much, Dr. White. Let me share my screen here for that introduction. And so we will be talking this evening about pressure injuries in persons with spinal cord injury. Are we moving towards innovation or convention? I have no disclosures. And so the outline for this evening's presentation is going to be an overview of spinal cord injury. We're going to talk a little bit about pressure injury in persons with SCI. We're going to look into some of the research and translation that is currently in the field, what kind of clinical implications we have for that, as well as takeaways. So, an overview of spinal cord injury. So, your spinal cord is a bundle of nerves that runs through the center of your spine from your brain stem to your lower back. It carries messages from your brain to the body and back to the brain. Your spinal cord is one of the main parts of your nervous system, and those messages help almost everything in your body work correctly. So things like controlling your body's movements and functions, whether those are voluntary or involuntary, like your heartbeat or breathing. Reporting senses back to your brain, so those things like pressure and pain that you might feel in your body, as well as managing reflexes. The spine refers to where the spinal cord is housed and is central to the entire human body. It consists of 33 individual bones called vertebrae, plus two sections of naturally fused vertebrae, the sacrum and the coccyx, located at the very bottom of the spine. It can be divided into 5 regions, and all of these bones and sections are important to the spine's ability to function properly. And each vertebrae has specific anatomical features and functions. So, what is spinal cord injury? And that refers to, or SCI, refers to direct injury to the spinal cord itself or damage to the tissue and bones around the spinal cord that can cause an injury, spinal cord injury. And this damage can cause temporary or permanent changes in feeling, movement, strength, and body functions below the point where the injury had impact on the cord. Typically, spinal cord injuries are categorized as traumatic or non-traumatic, with non-traumatic occurring from disease or degeneration of the spinal cord. So how SCI affects sensation and movement? SCI is classified according to a person's loss of motor and sensory function. And the two main types are tetraplegia and paraplegia. And so generally, the higher up the injury to the spinal cord, the more severe the symptoms. So for example, an injury at the C2 or C3 vertebrae in the spinal column affects respiratory muscles and the ability to breathe. A lower injury, say in your lumbar vertebrae, may impact nerve and muscle control to the bladder, to bowel and leg movement. Incomplete tetraplegia, which is could be paralysis of both arms and legs, is the most frequent neurological category, with incomplete and complete paraplegia, where that is paralysis in the trunk or lower legs, um, being virtually the same in terms of frequency. There are three clinical stages of SCI, and depending on your source, these numbers may slightly vary. Um, the acute phase being hours to days, maybe weeks, and this is typically the spinal shock phase. Subacute being any time up to 6 months, and chronic phase being anything 6 months and over, typically years. And so when we talk about some traditional SCI demographics, um, looking at this infographic from the National Spinal Cord Injury Statistical Center, we see that there are roughly 300,000 people living with spinal cord injury in the US, with about 18,000 new injuries each year. Most cases are due to trauma, including falls, motor vehicle accidents, or violence. And males are the most commonly affected, with consistently higher prevalence and years with disability. But we're seeing some change in these SCI demographics. So the average age of SCI is increasing. For example, in the US, it used to be that injury would be around between range from 18 to 30 with a mean age of 29 years. And then within maybe the last 10 years, we've seen the age of onset increase to around 43. And in Canada, we're seeing an increase by 13 years. So we're seeing folks having injury onset later. We're seeing less length of stay for acute hospital stays as well as rehab. And so this contributes to, some of the challenges that we're seeing in terms of development of secondary health conditions, which is what we're talking about here today. So in addition to these changing age demographics, our older population in the general population is constantly increasing. So we're seeing global numbers of people aged 60 and over increase. And so when we think about aging folks, we tend to think about high risk for falls. And we're kind of seeing that here with our SCI demographics, is that motor vehicle accidents and things like recreational activities were the contributing or the leading causes of SCI. And so now, as we're seeing this age demographic change, we're also seeing an increase in falls, SCI related to falls. And so there is a QR code there at the bottom. So if you're interested in looking at this particular article, that QR code will take you to that manuscript. So in general, spinal cord injury is a very complex condition that not only affects the sensory and motor pathways below the neurologic level of injury, but it also impacts all of the organs and systems below that level of injury. And so you can see that there's a number of different um, systems here in the image, but today's focus will be on the integumentary system or the skin, looking specifically at pressure injury. So pressure injuries result from prolonged or intense pressure on the skin and underlying tissues where blood flow is restricted, leading to a lack of oxygen and nutrients, which can cause tissue damage and open sores. Pressure injuries often occur over bony areas of the body. So in the pictures here, that would be the blue dots. And so that includes areas like your heels, your hips, tailbone, elbows, because these areas tend to have less padding and are then more susceptible to pressure. So throughout this presentation, as well as in the literature, you may see pressure injury or you may see pressure ulcer or bed sore. And these are often used interchangeably. And so it really depends on where you are in the world as to what terminology you will use. Um, Pressure injury simply means that tissue is injured by pressure. And in 2017, the National Pressure Injury Advisory Panel, or NPIAP, changed their terminology from ulcer to injury to reflect a more inclusive or accurate label of what's happening, the phenomenon, because not always are pressure injuries open ulcers, but they can still be classified as tissue injury. So pressure injuries in spinal cord injury is highly prevalent. Up to 30% of patients with chronic SCI will develop a pressure injury, and around 49% of patients in the acute rehab phase will experience a pressure injury. And spinal cord injury itself is a risk factor for developing pressure injury because of the intrinsic and extrinsic alterations that uniquely contribute to its occurrence. So things like reduce vascularity, cutaneous hypoxia, decreased movement, decreased sensitivity to sensation, temperature, all of those things can cause onset of pressure injury. And it is disruptive. So it curtails activities such as social functioning, rehab goals, things like contributing to hospital readmissions or extended lengths of stay, and so overall quality of life. There's also some evidence that depression in people that are hospitalized with spinal cord injury and develop pressure injuries can go on to have suicide ideations or suicide attempts. And so moving beyond just having a one-time pressure injury, recurrent pressure injuries are also particularly significant for this patient population. And evidence shows that around 70% of individuals with chronic spinal cord injury will go on to have recurrent pressure injury. And so the development of one is already severe enough, but having recurrent is not only problematic for quality of life, but um, the extended care that's required can lead to further complications and even death. So when we think about what kind of research is out there in um, the pressure injury space as it relates to people with SCI, research priorities include things like knowledge gaps, understanding where um, effectiveness of specific interventions come in, how we're using implementation science, investigating how effective our evidence-based practice interventions are, having specific patient population guidelines, which is what we're talking about here this evening, as well as cost effectiveness of treatment approaches. So I want to take you through just a little bit of the literature around key areas in pressure injury research. So we're talking about risk assessment, prevention strategies, treatment interventions, understanding the pathophysiology, as well as quality of life measures. So, although when we talk about risk, there's some controversy around what are the precise mechanisms of etiology where it comes to pressure injury and SCI. And although the literature lacks consensus, it is clear that it is multifactorial and complex. And as we said previously, there's literature that cites having a spinal cord injury as a risk factor in and of itself. So the three main categories that we tend to see around the risk literature is biomechanical or physiological categories such as shear and friction, maybe loss of nervous system communication, which is the sensation of telling people to shift their weight. Systemic health factors and comorbidities such as nutritional status, the presence of other conditions such as diabetes or conditions impacting circulation, even history of pressure injuries is considered a significant risk. And then rehab and patient-specific factors, so things like demographics, advanced age, education, and or injury characteristics. And so looking at these two articles from 2009, which was a while ago now, this particular review looked at some risk factors that stratified across acute and chronic spinal cord injury stages. And they again categorized these risk factors into socio-demographic, factors related to SCI, factors related to clinical conditions, and then factors related to individual behavior. And what they found was that the evidence in the acute SCI management um, was pretty low, and it was also discordant or inconclusive. And so while things like pre-hospital factors, getting people to the hospital in time, how long they may have been in a particular position, were things that were considered risk, the evidence around those were not necessarily high level evidence. And then in the chronic, the part two of this, they found that things like demographics, gender, education, work status, marital status, age at the time of injury are all risk factors for pressure injury. And those seem to have pretty moderate to strong evidence for risk. So when we fast forward to 2020, there was a similar study done by Silva and colleagues that looked at rehab and post-rehab risk factors, which would kind of fall into the same space of acute and chronic. And they pretty much found the same things. What they found in the rehab phase, risk factors included things like level of injury. So if you had tetraplegia, if you were a complete injury, if you had low scores on your functional independence measures, and a history of recurrent pressure injury, those tended to be highly associated with pressure injury. And the risk factors after rehab or community integration were the same as what we've seen in the 2009 studies. And so again, you can click on those QR codes if you are interested in doing a little more in-depth look at that study. And so prevention behavioral risk factors, relieving the pressure, careful skin monitoring, lifestyle, smoking behaviors, things of that nature have been discussed for some time, and are looked at as primary prevention strategies because they're actionable. They're things that we can intervene on. But, but in the literature, there is some, again, discordance around whether or not these are actual things that um, are truly impacting how we can have prevention, at least whether or not they're consistent from person to person. So while interventions focus on improving self-care, having self-efficacy, establishing social supports in other chronic conditions, such as like hypertension or diabetes, the evidence around patient behavior change alone in pressure injury is it's inconclusive. So I have a quote here from Kogan and colleagues that there is no positive evidence to support the efficacy of behavioral or educational interventions in preventing pressure ulcer. This was pre the change occurrence in adults with SCI. And so basically, what they're saying or their takeaway from their study is that a singular focus on behavior minimizes all the multifactorial things that contribute to pressure injury development, which can include things like genetics and microenvironmental factors. And if we look at a similar systematic review from Groa and colleagues in 2015, they also find the same thing. They found that based on existing evidence, um, current guidelines cannot be considered evidence-based, and that there should be consideration given to um, reevaluation of existing guidelines based on turning intervals for this particular high-risk population. So right now, there are guidelines out there around turning every 2 hours or doing pressure release every so many minutes when you're up in your chair. But unfortunately, the grade of evidence around these interventions are not strong. So that just means there's more work to be done. Now, the bulk of published research really focuses on wound healing rather than prevention, because as we saw, there are some challenges there. Um, and so when we think about development, we're talking about the process of wound healing. And there are 4 phases of normal wound healing. We're talking about um, hemostasis or bleeding and clotting, um, inflammation, the kind of cleanup of the scene done by cytokines within the first few hours of injury, proliferation phase, which is the establishment of new fibrin matrix, um, the replacement of capillaries and vasculature to restore circulation in that space, and the beginning of granulation tissue and epithelialization. In the final phase, we see remodeling, where is like the more final phase of wound healing, where we see the scar or that new like baby skin that starts to grow in. However, we want to be careful during this remodeling phase because that tissue is not as strong as the normal tissue that has never been wounded, and so um, this leaves this kind of new skin vulnerable to potential re-breakdown. And so when we think about pressure injury, that what we described here is what you think about when you maybe do a cut on your hand or your arm and you get a scab and then the scab falls off and your skin starts to go back. But when we have this prolonged and complete and uncoordinated um, healing process, this is what leads to chronic wounds, such as pressure injury. And these conditions promote, we said that the loss of oxygenation and blood flow and infection and increased pressure can lead um, to these types of wounds. So in thinking about that space in the research, we know that people with SCI are at increased risk for pressure injury development, and their susceptibility to pressure injury recurrence seems to vary. And so we know that it's not just behavioral or lifestyle, but there may be genetic factors that are predisposing people um, to be at higher risk. And so genomic profiles have demonstrated increased intramuscular adipose tissue that can lead to recurring pressure injury risk. And there are also genetic variants that have been identified in both of these studies that demonstrate that there could be genetic basis for um, recurrent pressure injury. And then lastly, talking about treatments. And so I don't have specific treatments here because it really is going to be dependent on the type of wound that there is. But the goal of treatment is really to promote healing, prevent infection, and minimize scarring. And so again, it depends on, the depth of the wound, what kind of exudate there is, what stage it's at, as to what will be the best type of dressing. So I've just included some images of different types of treatments that are currently out there on the market. So I think we can all agree that people living with SEI are at high risk for developing pressure injuries over their lifetime as a result of immobility, lack of sensation, and other physiologic changes. Skin breakdown can delay rehab and interfere with different educational and vocational pursuits and just complicate the community reintegration period. And so, our treatments for SEI or for pressure ulcers in SEI requires prolonged periods of bed rest, which can exacerbate social isolation, um, as well as a loss of control and just overall poor quality of life. So we've got to think of better ways to intervene once pressure injury has developed. And so, you know, as we looked across some of these articles that we pulled out, there are limitations and challenges in this space. And one being that there's insufficient evidence to really support a lot of our preventive measures um, or interventions, including things like repositioning and nutritional supplementation. There are methodological deficiencies, excuse me, in our studies because we have small sample sizes. There's lack of standardized definitions and ways in which we report, as well as ways in which we determine what treatments to do, practice protocols. And so that makes generalizability of existing studies just highly uncertain. And we can't really apply it to all people, or even say that there are certain, groups at this point because we just don't have the evidence. So again, there's more work that can be done. And one of the ways that we can do that is through things like precision rehab or precision medicine approaches, which we'll talk about a little bit more in subsequent slides. And so clinical implications. So we have this body of research where we understand that there are gaps. And we know that in clinical practice, it's easy to consider research as kind of its own space. We have busy inpatient units and outpatient clinics. So how do we get research into clinical practice, particularly in wound care, that is going to benefit the clinician and the provider? I mean, and the patient. So wound assessment, wound treatments, all of that, we know that having the best evidence is going to really impact positive outcomes for the patient. So things like implementing treatment in a standardized way, a systematic approach, allows clinicians to critically assess whether or not what they're doing is efficacious, if new or existing treatments are really appropriate, if we need to improve the standard of care through these new ways of doing, or if we can reuse things that are already established. But we also understand that there is variability in provider practices. So that means that we do understand in the literature that healthcare provider education around wound care is primarily done in the clinical setting. So it may be introduced in the healthcare curriculums for physicians or nurses, but where they actually get hands-on understanding of the treatments and so forth is going to be once they're already in practice. Um, and so that really doesn't provide them with the resources that they need to assist their clinical decision making or their patients, particularly if we want them to impact patient behaviors. And that also impacts how we educate caregivers in things of what to look for and how to implement the care plans that they're developing. So, so there needs to be some standardization around our screening tools because they're going to vary from unit to unit, hospital to hospital. And so having some consistency around that will allow us to be able to compare um, research findings across institutions. Documentation, how we're measuring wounds, how we're reporting wounds, and then treatment planning. So having that open communication and mutual goal setting with the patient and the provider can actually help improve patient adherence to recommendations, lending itself to more of the prevention. Also, we know that self-directed monitoring is a critical piece because this is how we know that what's happening with patients, particularly in the community. Um, in the inpatient rehab setting, we have 24-hour, nursing service that is checking on these things. But in the community, there's higher risk or higher opportunity for pressure injury to develop, particularly if there are behaviors or lifestyle that goes against what may be needed for that particular patient. And so that involves things like daily skin checks, understanding their individual risk factors, because as we heard, it may differ from person to person. Regular pressure relief and proper nutrition are all important preventive measures that the patient can handle. And then there's this opportunity for us to use technology and AI supported um, inspection, such as the use of smartphone apps that remind you to do the daily skin checks or remind you to do pressure relief. May remind you that, have you had water today? Thinking about nutritional supplementation kinds of things. Wearable devices allow us to be able to collect information in real time. And, depending on the level of injury, it also can empower the individual to, independently do these types of monitorings. So the like habit camera will allow, it has the flexibility to allow individuals to look at their skin, whether they have compromised hand or arm function, so that they can then start to look for those crucial key early signs such as redness or warmth or skin breakdown, and share this with their provider. And so the Wound Healing Society just recently came out with its 2023 guideline, which is a compendium of the best available evidence for the treatment of pressure injuries. And this was published in 2025, or excuse me, in 2015. And it now includes a new section based on, changing evidence. And so it includes information about palliative wound care for seriously ill patients with pressure injury. And really, the goal of the Wound Healing Society Guideline Project is to present clear, concise, and commercial-free guidelines for clinicians that can guide care and clinical decision-making, as well as researchers, so that they can go on to develop studies that will improve treatment and allow clinicians and researchers together to use this to further understand the gaps in our knowledge base. And so, in general, clinical practice guidelines from organizations such as the Consortium for Spinal Cord Medicine or NPIP, these are good resources for evidence-based practice recommendations. However, because of the paucity of pressure injury research that's specific to SCI, there are considerations that need to be taken. It's also um, really interesting that there's now AI interfaces within the electronic health record that will allow certain guidelines to be embedded so that during uh, that clinical engagement, clinical appointment, they can actually pull up guidelines at that time and look at the best evidence practice. And again, the QR code will send you to the latest guidelines. So in takeaway, um, SCI is a medically complex systemic disorder, and it uniquely contributes to the occurrence of pressure injuries. There is a critical need for more research to support our understanding and fill in the gaps in our knowledge base, but also to advance precision rehab efforts, because prevention and education for patients, providers, and caregivers, is the best thing that we can do. However, doing this from a precision health or precision rehab lens allows us to consider the patient's unique genes, their environment, and their lifestyle to really tailor some disease prevention and treatment to the individual patient needs, so that we have the goal of providing the right treatment at the right time based on the patient's predicted response to risk of disease. And with that, I thank you for your attention and your time, and I'm happy to answer any questions.
Thank you so much, Dr. Graves. If anyone who's on the call would either like to ask a question or can put something in the chat, the Q&A, excuse me. Just give it a minute. While we're waiting for those to load, as I mentioned before, I'm a geriatrician, and one of the things I've been kind of curious about, especially how, the cause, I thought was super interesting, the cause of spinal cord injury, how that's changed over time, and we talk often about falls and the detriment of falls.
Yes.
But also thinking about just longevity in general and people who are living older with a spinal cord injury, whether it happened when they were young, or in their older age. And I'm curious if you could talk a little bit more about that.
Yeah, that's a great question. I was just on a call earlier today that was from some of our partners up in Canada, and they were talking about the same thing, seeing the difference in mechanism of injury and how typically we're seeing things, related to recreation and, some of the more I'm missing the word that he was using, but basically the more active people are, they are at risk for, developing spinal cord injury based on like, mountain climbing or, just that recreational piece. I would say motor vehicle accidents are still the leading cause of spinal cord injury. Um, but now that we're seeing this shift from primarily young people getting disability early in life and then living long with disability, that even looks different. And we still don't really fully understand what are the nuances of difference for those folks that are having these injury impacts to aging versus those folks that are having aging impacts to their new injury. So I think it's interesting that we'll continue to see as this unfolds because I think um, what I'm seeing across different agencies and organizations is that there is this understanding that there are age-related implications that we need to better understand for this patient population.
Thank you. We do have a question in the Q&A.
Mhm.
So which genes are found to be predominantly associated with SCI and pressure injuries? Do current anti-inflammatory agents offer any help?
That is a great question. So in the study that we did in 2023, we found that there were some genes that were associated with inflammation. We found that there were genes also in the senescence pathway, and as well as some metabolic pathways. So um, some of that analysis is still ongoing because it's kind of multi-omic, so we're looking at it both from the genome as well as the transcriptome level. So I would say that that next paper is coming soon with more details on those specific genes, but we do see that there are overlap in the different omic, analyses. So I think what's interesting is that what we're seeing from like data-driven results in terms of looking at EHR or lifestyle surveys that say, you know, age is, causing high risk. So now we're able to see at a biologic level that it is in fact related to biological aging. I'll say so. I think as we continue to unpack some of that analyses, we'll be able to find some more specific genes.
Thank you. We have another question, a little bit broader.
Mhm.
Just wanted to know more on how genetics impact on pressure ulcers. I'm going to make a guess here, meaning maybe inherited conditions, but okay.
Yeah. So that's a great question. I think, when we think to traditionally about genetics from that standpoint, we often think about like familial, what's passed down from your parents. And unfortunately, it's really hard to do that in such a heterogeneous population. Um, so what more so we're seeing and kind of the work that I'm doing with the social epigenomics is that there are things that are kind of switching on certain genes or turning certain genes off, um, related to, these lifestyle things, such as maybe their neighborhood. We know that certain neighborhoods put people at higher risk for developing certain secondary conditions. Stress, we know that stress is significant. Um, this particular patient population has this kind of baseline ongoing chronic inflammatory state. And we know from other conditions like diabetes and hypertension, and cancers that having that ongoing inflammation is not healthy. And I know that at the acute phase, we give things like methylprednisone to, decrease some of that inflammation. But again, we have such small sample sizes for these studies, that it's hard to really determine if it's actually if it's efficacious as we think it is. So some studies will say, yes, do this as a front line. And so for some patients, it's protective. And then for some patients, it's not. So, I hate to like bang the drum of like, we know, but we don't know because we don't. I'll say there's still a lot. And there's so much complexity to what all is happening at a biologic level for this population that we're still really teasing a lot of that out. I think maybe within the last 20 years, we've really started to get more into the genomic and the multi-omic, the precision, piece of this. Of research in this space. So I think we still have a long way to go, and we preliminarily know, but yeah, there's so much more that we have to do. Thank you for that question. I hope that answered it in some way.
And I think we have time for a couple more questions. So
Sure.
a follow-up from an earlier one, but wondering if these pressure injuries were also common in defense personnel, such as veterans, or they also mentioned Air Force, which is part of the military.
Yeah, yeah, that's a great question. And in fact, yes. So a lot of the work that we have been doing has been around um, individuals in retired, military folks. So most of our work is in veterans. And so I think it would be really cool to be able to compare what we're finding in our veteran population to civilians, because I think that there might be environmental things that are impacting how certain genes may be showing up that may be specific to theater of combat or just, military background. So yes, I'll say, let me see, that question was more about just military in general, or I want to make sure that I'm,
I think, yeah, or just, I think they were asking defense personnel. So
oh,
yes.
yes. Yeah. So, and
Yeah.
I know that there are studies being done in active military folks. I'll say we are not doing that piece of the work. And I think more of that work is probably found in like traumatic brain injury. Um, and I think that some of our Canadian neighbors are doing a lot more work in the acute phase. But I don't know that their patient population necessarily has military background.
Got it. And then the last one we have here that I think we have time for.
Uh-huh.
If metabolic pathways are involved, what about APOE? Um, they felt that would be interesting to know, and they're waiting for your article and publication.
Yeah. Yeah, that's great. I we have not seen ApoE show up yet. I'll say a lot of what we're seeing is like glucose metabolism, fatty acid metabolism, which does support the IMAT findings around intramuscular adipose tissue conversion as people move from muscle to fat. So I think those are the things that we're immediately seeing, but again, there's still analysis being done. So yeah, so keep an eye out for that paper. I hope that's coming out here in the next month or so.
Well, I want to thank you very much, Dr. Graves, Dr. Bogey. I didn't know if you had anything else you wanted to add.
No, I think that was a great talk. Thank you very much. And I'm glad to see such an engaged audience.
Yes.
Um, so I think all that's left for me to do is sort of thank everybody for attending this webinar, which was brought to you by the Wound Healing Society Education Committee and Wound Healing U. And if you missed anything, if you didn't get to scan the QR code quite quickly enough, the recording will be available and your member-only account on the Wound Healing U and Wound Healing Society YouTube in a few weeks. And on April 22nd, we are going to have a slightly different webinar. It's actually going to be a debate on tissue engineered grafts. So I look forward to seeing many of you there. Thank you very much. Good night.
Thank you. Good night.